Hmm.
We're going to talk about data, and then I think we got 2 more questions, and then we kind of going to talk about that. But so for the research now, you've talked about institutional discrimination, you've talked about socioeconomic disadvantages, you've given an example of how that can lead to overrepresentation of minorities in toxic residential or occupational environments. So we know from research that leads to elevated risk of exposure, which you've touched based on, to major hardships, conflicts, disruptions, like you said, crime, violence, material deprivation, loss of loved ones, which we have experienced during COVID, recurrent financial strain. And when you put all of that together, that is a lot of psychosocial stressors on a community. And how can that impact the socioeconomic status or be even a disadvantage among Black and Brown communities?
Oh, yeah, that's a lot. It's a lot. And sometimes even working in this field full time, like it's a lot, just period. There have been days when we're in meetings together and we're all sitting there just looking at each other like, wow, where do we even start? So just to highlight something that you, like one of the last things that you mentioned, you asked me about the disparities for Black and Brown communities. And I'd have to say that even though there are disparities for both groups, it is interesting to observe that while the health conditions for Brown communities are improving, health conditions for Black communities are not. Obviously, I want to see improved health conditions for everybody, regardless of who or what they look like. However, we cannot ignore the differences between the two, even though they share so many similarities. So honestly, I don't believe that we should combine Black and Brown communities into conversations when we have them, simply because the trends are completely different. So like, for instance, the disparities between non-Hispanic Black individuals and the population with those who are Hispanics, they have the best rates for improved health outcomes right now. So they're up 13% as far as health disparities. And it's really interesting because for a long, long time, the trends were almost identical between Black and Brown communities. Mm-hmm. And so I think it's powerful to highlight the differences because it helps us see, what is it that turned that number around? Because it was trending down for so long, but now it's trending up. What changed? So if we can figure out what changed, we might be able to go back and duplicate it and tailor it to the Black community as well. So I did want to highlight that because I think that there's power in that. Again, there's power in the data, which, you're a doctor. So, but anyway, get back on topic. So the mechanisms through which social determinants, including racism, exert their effect on the Black health and the Black community, we have to be able to talk about it at both the macro and the individual levels, because that's what it's going to take to really address it from the institutional level. So institutional, we're looking more at the broad spectrum of things, and then we're looking at it on the individual level later. So but this also takes into account poor housing and work environments and all of that stuff. So we have many different factors surrounding physical environment, which we talked about. We have, you mentioned elevated risk of exposure to hardships and crime and violence and loss of loved ones. All of this stuff is directly related to, again, negligence. Almost every single factor that I can think about as it pertains to the physical environment, whether it's, excluding weather or geography or topography or something like that, like But things like air quality and housing, all of that stuff, it directly correlates to neglect. We have other human-made influences that also affect health, as well as contribute to health disparities, but they don't really receive enough attention. So you have the quality of our housing, like I mentioned. You have asthma that is directly related to poor housing, which is why our Black children carry the disparity for asthma, because a lot of them live in poor housing conditions.
Yeah.
There's this, I mean, it irks me to it. Sometimes, it just bothers me just why I do this. Then you have segregated housing that's also correlated with a significant increase of CVD. And I mean, look at the projects, for crying out loud. Who primarily lives there?
Yeah. Yeah.
So again, I mentioned earlier, location is such a vital component. And so, Casey, you brought out a point about the middle income versus low income, and that's why location still plays a part, and that's why middle income is not entirely exempt from experiencing some of these things, simply because a lot of middle income individuals still live in areas that are not up to par. They still live in homes that are not up to par.
Yeah.
Or have family that's in, so you're touching on something that, like, intergenerational stress,
yes,
intergenerational poverty, intergenerational low education, low income, that you can make it in the highland of glory, okay? But if all your family is in a situation, now it's the stress of having to manage all of that, so it's not like it never leaves you, in a sense, because it can last for a while. Your mom, your older grandparent lives by themselves, or multiple people still in your family live together in a certain community. That can still be, sometimes in Black and brown communities, it can still be on the one who is now, higher income, moved out, got the degree, all that stuff. And they're the primary caregiver of the family that has to take on all of that stress. Mm-hmm. And so I think you've kind of brought up, like, just the mental stressors that can really affect communities, neighborhoods, and it can play a toll even, in healthcare as well, because sometimes we don't like root cause issues. We won't go there. But sometimes I know sometimes we just don't want to we get a pill, we get this, we get that, but we just don't ever get to the root cause or the holistic thinking. So I think that we got to put all of that together, the healthcare system too, is what, the single parent that, in the ER, they struggle because they gotta leave early because they gotta take care of the kids, and there's no one to take care of them. So now when COVID hits, now that increases stress because they're the only income. They may not have relatives that can go and take care of the kids. Now, if they have an emergency, need to go and make an appointment, they can't bring the kids along anymore. So it's like that chronic stress, and how that can weigh on a community is something, we're still learning how to address. I would say that.
We absolutely are. Again, I spoke recently on one of my videos on YouTube about this lower level of chronic stress that Black Americans always have. Not even just Black Americans, but minorities in general, simply because of microaggressions, different things that they're experiencing, even at work, the inequalities that they receive at work. I'm not even going to get on that right now. We might talk about it later. But there's always something there. And you touched on so many of them. And I'll also add, like, even for people who do get an education and make it out, and for those who can't see me, I'm using air quotations because that whole make it out of the hood and everything, I feel some kind of way about that. I don't think that we should always try to make it out of the hood. Anyway, I didn't go there that deeply into it, but a lot of times individuals who are high earners and who have families that still live in poverty, they can't develop generational wealth or economic stability, not for real, because they are also giving money back to their family members. Right. And so it was really interesting that I attended a roundtable where we were talking about generational wealth development in communities of color. And that was one of the key things. It's like, yeah, okay, well, you make $250,000 a year, but number one, you're trying to keep up a certain lifestyle. Mm-hmm. You're sending money to every cousin, your parents, your siblings, like you're hemorrhaging out the side. You can never really invest your money or grow your money like you need to develop something or create something for your children. This is impacting your legacy. And so, yeah, this thing is deep. But so back to answering your original question, something else I would really highlight is transportation. It's often a problem in poor communities, and it presents obstacles to accessing healthcare services, especially preventive care services. That's like, I mean, I'm a doctor of preventive medicine, so like this is what I care about. Like people are not getting to their screening appointments, and when they're in primary or secondary care, they're not able to attend their appointments like they need to. And so you get people that are very, very sick. Okay, well, now you're giving them access to transportation. Why did you give this to them when we could have stopped the disease, the condition that they're suffering from? So that's a huge problem. And so like even within the policy space, there needs to be more access for transportation. I know cities like DC, we have partnered with Lyft and Uber, where they will come and pick up, your patients or your enrollees and bring them to their doctor's appointment. But we have to be creative in how we are addressing these different things. So yeah, it's just, also, I wanted to point out that Black people are significantly more likely to reside near sources of air pollution, like I said earlier, but we also live in communities that they don't have quality monitoring sites in these areas, which is another problem. So how are you going to have communities that live close to high pollution areas and you're not monitoring the air quality? Like that is a social injustice in itself, because it's almost like you purposefully, the air quality is going to be poor here. So that's why you choose not to monitor it, so it doesn't reflect negatively in the total numbers. Because if you did, then you would have to address it. And so things like that, from a policy standpoint, they should be required to have monitoring around certain sites, regardless of what the politics are around it, just because it just should be.
It should be.
So when you talk about data, and you're talking about, this is the point where I want to talk about data, and how, like, the issue with Flint, just to kind of summarize what you're saying, you hit it right on the nail. Monitoring has to improve, regulating has to improve, and remediating issues. And I think those are the three things that were not there in Flint, and when you talk about data, public health funding has had its issues over years, decrease often every year. There's a change in funding. We'll say that nicely. There's a change in funding. In the research that surrounds social determinants and health disparities, which comes into that monitoring, regulating, remediating, all that stuff. So how can that reduce public health funding behind the research of those vulnerable populations, the vulnerable issues, impact our future healthcare system?
Very, very good question. And I will say, because when this happened, I was actually doing some research that was funded by ARC. So ARC is the Agency for Healthcare Research and Quality, I believe. Yep. So anyway, so in 2016, ARC had a major decrease in funding. I believe it was $30 million that was cut from the budget for it. Mind you, the total budget is huge because, research around not even just SDOHs, but just healthcare quality period it's a big number. So, but $30 million is huge. And so this particular set of 30 million specifically went to grants and research. And as we know, like this was done by the appropriation committees in the House and Senate. I have to be careful what I say to some degree from a political perspective, but that's what happened. And so ARC requested an additional increased level of funding so that way they could restore important programs like the NGC, which is the National Guideline Clearinghouse, and then the National Quality Measures Clearinghouse, which also helps drive this research and give this data. And so the NGC in particular plays a very, very important role in clinical decision-making and like the clinical SDOH work. And so ARC was really forced to make some hard decisions to decide where to make the cuts. And people wanted to cut SDOH funding out altogether, but thank God they did not cut all of the funding. That would be catastrophic. But they had to because it was such a huge hit. I mean, $30 million is, I don't even know what $30 million looks like in real life. So I can't imagine how many programs were impacted by that. But anyway, and I don't say this to minimize the importance of social determinant research. I just wanted to clarify for the people who are listening why there was such a huge reallocation of funds. And it's because the government said so, basically. We can thank our current administration for that. So
not just for that, for trying to get rid of Obamacare as well.
Well,
Affordable Care Act.
Right. Thank you for that. No, but I mean, my thing is like, if you're going to complain about something ever in life, don't come to me with your problems if you have no potential solutions that are remotely going to work. The AHCA was clearly not going to work. I mean, anybody who delved into the details of that is like, dude, really? And you want to do block grants for Medicaid? Have you lost your marbles? That's not going to work. Like, and then look at stuff like COVID. Can you imagine if there was no ACA and we adopted the initial proposed replacement for the AHA during COVID, if Medicaid was essentially a block grant? So a block grant basically is like, or a per capita grant, it's like the amount of heads or the amount of people. So capita means head. Anyway, so I like to just explain, maybe over-explain stuff sometimes, but it would just mean that, so we maybe allocate hypothetically $10 million to address 10 million people. But in situations like COVID, clearly there's so many more people on Medicaid, 10 million people, we wouldn't have a program. We wouldn't be able to address the needs. So anyway, that's behind us, thankfully. Hopefully the AHCA never sees the light of day. But I will say within that, getting back to the original question, social determinant research is one of the areas that was cut. It has a huge budget, but there are many, many, many healthcare quality topics and initiatives that are being researched, and they're being researched well. And so they're finding a roundabout way to address SDOHs from that perspective, even though they're not being, it doesn't have its own budget anymore. So that is really good. I do applaud the individuals at ARC for making that a priority. And so within that research, they do a ton of stuff around systems research, around practice improvements. So this is going to be providing tools to healthcare organizations to help them address social determinants. There's also a lot of research around data and analytics, as you can imagine. So developing data sets and analytic tools to help create the understanding of social determinants, which to me is my favorite part, because this is what we are going to use to help create policies to address everything else that we've talked about today.
Yeah.
And so there is some work doing around that. And actually for people who are interested in learning more, you can just Google ARC, AHRQ, and social determinants, and their website should come right up, and you can learn about some of the specific research interventions and also how you can get involved. So I'm really, really huge on getting people involved and mobilized, because it's going to take all of us. You do not have to be a healthcare provider or practitioner or have a background in healthcare to do this and have your voice be heard. Just get involved. There's stuff in every city. And so ARC is really, they're really driven to generate the evidence that's necessary to build a really high quality, high value healthcare system, which it is a blessing and a curse as someone who works in healthcare quality full time. There's a lot of hurdles that we have to jump through, but it's for the betterment of the community. And it also helps healthcare organizations remain accountable, which is not something, to your point, Shannon, it's not something that has been done consistently, and it hasn't been a requirement. So I do appreciate that they are requiring more hospitals and private practices and health departments and just communities across the country to maintain a level of accountability, so that way we can be more efficient and effective. So,
Good. Good. So we have a question. I'm going to read one question from Facebook that we received before I turn it back over to my wife to ask the final two questions. And it says, and I'm going to read the fourth word for word. As a registered dietitian nutritionist, I know that food is political. Food industries target certain people to buy specific food, and big endorsements are given to companies who sometimes have no internet in their health. Not having access to good quality food because of the neighborhood you live in is where I believe a lot of it start. So as healthcare providers, should we be aggressively partnering with companies or organizations to help improve access of healthy food for our patients?
I love this question. As someone who owns a lifestyle-based business and focuses largely on nutrition, I love this question. And I say yes, absolutely. We should encourage publicly and private managed facilities that serve children, especially those such as hospitals, after-school programs, recreation centers, parks, and not even just children. I think we should start there, because I say children because I do believe it's going to take starting at that level, not just adults. And I'll get to why that, I'll explain more in a second. But anyway, so getting these facilities involved to help implement practices and policies and be consistent with the dietary guidelines, even though I take slight issue with some of those dietary guidelines, but anyway, we're not even going to get into that either. But we want to promote healthy foods and beverages and reduce and eliminate the availability of calorically dense and nutrient poor foods. So I say start with the children, because when I lived in Michigan, we did an intervention in Benton Harbor, and we saw that sometimes when you go to adults and you tell them what they need to do from a lifestyle perspective, it almost goes in one ear and out the other. It doesn't always happen that way, but sometimes it does. What I have found, what the research has found, is that sometimes the best way to get to adults is through their kids. Mm-hmm. If you have an intervention going on at the school, if you have practitioners who are telling me, hey, your kid needs X, Y, and Z in order to be healthy, the parents, because they have to buy it, the stuff is now in the house, they're more likely to also eat the same food as children.
Yep.
And so for me as a behavioral lifestyle specialist, this is something that I have seen work wonders in families that it was like you talk to your blue in the face when you're talking to parents about their own behaviors, because you're trying to break 30 and 40 years of bad habits. Whereas children, people care about kids. They just do. So maybe it's not a scientifically proven way, but I have found that it does work. So, and also if we start talking about breaking generational curses and challenges, we have to start educating our kids, because real talk, and I don't mean to sound like Debbie Downer #1 when I say this, but some points are always going to be mute for certain adult populations. People are set in their ways in some instances. And while I don't say we abandon health education on the adult level, that's definitely not what I'm saying. But I do think that some of the residual efforts by educating the kids would naturally start to reverberate throughout families and communities. Another thing that I would say is to encourage the establishment of regional, city, and county food policy councils to enhance comprehensive food system policy that improves health overall. And I would bring this even further to ask them to outline it for different populations. So if you look at the typical dietary guidelines for people who are plant-based, it says nothing there about how they should eat, if they're not eating meat, what should they eat to, consume proteins, but just to make it specific enough and give credible scientific evidence based on which foods promote more longevity. Because I'm careful about what I say, because I don't know who's going to listen to this, but at the same time, it is what it is. The stuff that we promote as healthy food in this country, I don't want to say 9 times out of 10, but a large percentage of the time is not really healthy.
Yeah.
Some of the,
I can imagine.
Some of the sources of protein that we tell people, oh, you should eat this. This is good for you. Shrimp is not good for you. Shrimp eats fish poop. Why would you want to eat that? I don't care if it's low in calories. I don't care if it helps with your muscle mass. And yes, I'm using a very specific example, and I might be stepping on someone's toes right now, but please go read something that's credible about research and not just take everything that the government pushes down your throat as far as what is good and healthy for you.
Exactly.
Not. Why would you want to eat a lobster? It is literally the roach of the sea. It eats all of the garbage on the floor of the ocean.
Yeah.
I mean, we have to be very intentional about what we put in our bodies. And yes, even though it's another creature that ate something else, all of those molecules and everything is still being incorporated into your own personal biochemistry. So these food councils should be very understanding of different people's perspectives and how they wish to eat and what they want to have in their bodies when they're making these rules and these policies. So I say that not to sound fanatical, but there are tons, hundreds and thousands of people out there who feel the same way about some of these foods that I do. I mean, look at some of the vegetarian nutrition research that comes out of Loma Linda. Look at the blue zones around the world and these centenarians, these people who live to be over 100 years old. Look at what they eat. They don't eat anything closely resembling to the typical American diet. People in Sardinia and in Okinawa, Japan, and Loma Linda, some of these places where people live to be 120, 130 years old, they don't eat this stuff. And there's a reason. It is not good for us.
Now, just to touch on that, here's the thing that I always get when it comes to diet is that some people are like, okay, but what about your ethnic foods? Like there's some foods that just, I personally would tell you, I ain't trying to eat an oatmeal muffin. That's just not what I don't even eat that for breakfast. Like, that's just not what I eat. So I'm not trying to make it. I don't care for the oatmeal muffin for breakfast. You know, even though it's like, oh, but you can make it from scratch. I get all of that, but I don't, that's just not in my makeup, you know? So what do you do? I think what the audience may also want is, okay, but what about the ethnic foods? You know, a lot of you go Caribbean foods and stuff like that, you know, it's a different style altogether. It's just different. So, yeah, you know, I also think sometimes the guidelines make it, they pose it in a way that satisfies a certain group. I'll say, is that nice? I think I said it nicely.
You said it very nice.
Right.
Frame it in a way that is, yes, that works for certain populations, but there's others that have a entirely different, I mean, they just, everything's different, you know what I mean? And so I think trying to, you know, how to accommodate even them is a place that I guess we still need some work.
I just have to say, Casey, I love her. She's so awesome.
Exactly where I fell in love.
Shannon.
Yes, I'm just saying, like, I like my curry. Sometimes I do. Sometimes, you know, and certain ethnic they do. But you know, trying to teach as a clinician, you're trying to teach people. Okay, certain Asian populations they like a lot of rice, or they eat heavy meats like your pork, and you know, you have to be culturally aware of that and say, okay, now in what way can we adapt? Mm-hmm. You know what I mean? And I got to be culturally aware that if they're from a Jamaican background, their style of cooking, their ingredients are a little bit different. You know what I mean? And so not wrong necessarily, but just different. And so you got to really kind of get to know the patient and the population a little bit more to know what type of food are they buying, what taste buds they even have, you know. Oh, I can't convince a patient that to eat an oatmeal muffin when they're used to, you know, a spread. I just, that takes work. It takes a lot of work.
Oh boy. Oh man. No, I'm with you 100%. I'm actually getting ready to publish a vegan cookbook. It's a plant-based vegan soul food cookbook, actually. To your point, because I feel the exact same way. I'm a foodie. I like food, and I like food that tastes good, but also is healthy. So within that, within the health education realm of things, we call that tailoring. So you mentioned several great points, and you mentioned knowing your population. So I wouldn't go into an Amharic community and talk about, oh, you need to eat I don't know, something that they don't eat. You know, like, oh, you need to go eat green beans and quinoa. They don't eat quinoa. Like, you need to know what your target demographic actually eats. But there are healthy foods within all of these different areas that we need to be mindful of. And so if we want people to actually adhere to what we're educating them on, we should make it appealing to them by presenting information and foods and recipes or whatever that they actually like, not something that, I mean, food is such a huge part of culture.
Yeah.
And this is kind of off topic, but it's on topic. I totally, absolutely, I cringe when people say, I don't see color. I teach my kids not to see color. I think that I totally disagree, because color, it is connected to culture. And if you tell me that you don't see my color, you're telling me you don't see my culture, which means that you're not seeing me for who I am and what I have to offer to the world. And I think that there's beauty in seeing people for who they are, where they come from, what their personal preferences are, because that is what makes us human beings. That's what makes us different. That's how God made us. And so we have to be able to address people on an individual level, but also remember that they are individuals with their own preferences and history and all of that stuff as well. So yes, we should absolutely tailor whatever it is to who we're talking to. And we should encourage our communities to promote efforts to provide fruits and vegetables and foods in a variety of settings that are appealing, and encourage the establishment of direct producer to consumer marketing outlets, such as farmers markets and community supported agriculture initiatives. So that way they're producing and offering the foods that are relevant in different communities as well. But yeah, and I would say even from the government perspective, I would encourage local governments to create incentives to attract supermarkets and grocery stores to underserved neighborhoods that improve transportation routes and also help minimize some of these food deserts that we see in our communities as well. So, and have these real retailers, again, they should be specific to the community. If this is what this community wants, give them the types of foods that they want, that they, they're used to eating.
So you mentioned we, and this is where we have to pivot from a conversation to a more active role. And this is where even I myself have had to do some self-reflection and grow in this area of being a more active participant in these issues. So how can people in these communities play a more active role to address these issues, like addressing the root causes, initiatives on education, housing, employment, other health-related social issues?
I would say get involved and be loud about it. Don't just, I'm gonna passively do something over there. No, be actively involved. So however that looks, I know we're all busy. We all have tons of things on our plate. So what I try to but I try to give examples of how people can get involved. And I start with, what is your gift? What is your gifting? Your calling in life? What do you naturally do well? Because 9 times out of 10, if you start there, number one, it won't feel like an extra burden because it won't feel like work. It's something that you're naturally already good at. You're naturally already interested in. Find that and be that voice. So for me, like I mentioned my cookbook earlier, it's something that I'm very passionate about. I don't feel that there are many plant-based, ethnically based foods out there. Or
I'll get a copy.
I will send you one. You can go to my first one. But so that was something that I wanted to do, to give back to people who I know the same issues as me. But even you mentioned housing and employment, some of these major issues, there are collaborations and coalitions in pretty much every city I've ever been to. Mm-hmm. Like for instance, the DMV area, Baltimore and DC has the highest number of nonprofits per capita in the United States, I believe. I think that number is still true. That's saying a lot, because if every single nonprofit had enough people to go out and help, there would be no health disparities in this country. So that means that people are not involved like they should be. So figure out, ask yourself, what am I good at? How can the gifts that God gave me help other people? Like, what's the lowest hanging fruit for me to get started? And
so working within your sphere of influence.
Yes.
Yeah.
Wherever you find yourself, that just work within your sphere of influence, because that's 9 times out of 10, that's probably your gifting or calling. And if it happens to not be, or maybe you are a chameleon and you just got several giftings. I don't, maybe, then branch off in some of those other areas too, like you said, so that it's not necessarily a burden to you. It's just within your sphere of influence. And I guess that's what people are asking now, is we all have to take a deeper look into how we are playing an active role wherever we find ourselves. Mm-hmm. That probably, because your peers are around you, so you already have some form of networking within your sphere of influence.
Right.
Yeah.
Yeah. I mean, at the very least, let's just say you have a really good solution for a problem. And I don't think people really think about this, but you can write letters to your county and policy, your county and state legislators.
Mm-hmm.
Write them a letter and say, hey, I'm requesting a meeting with you about X, Y, and Z. Or if you don't want to meet with them, highlight your ideas and show them, like, hey, if you implement this, these are some of the changes that would happen. And so, like, in my class, one of the assignments that I have my students do is write a policy memo to do exactly this. Like, again, it's the initiative to help everybody get loud, get involved, speak your mind. And so they find an issue, and then they do like a SWOT analysis. And I know some people out there are like, I am not an academic and I'm not in school. I'm not trying to do this. But what are the strengths? What are the weaknesses, the opportunities, the threats? Fine. All this information is completely public information. You can find out what the rates are for certain things. So if you're talking about unemployment in your city, talk about the current rates of unemployment and how utilizing your strategy, it would help reduce the rates in that city. And you can use other cities, for example. So you might not even have to come up with these ideas on your own. You can say, hey, well, in LA, they did X, Y, and Z. And even though our city differs by, whatever elements that they differ, this might be something for us to look at to implement here. And this is what this might look like. Simply stuff like that, simple things like that. I had a student actually have one of their ideas implemented just from this one assignment. And this is a student. So just imagine if we who are working, we've gone through school, we are professionals, if we simply write letters and take the time, even a week of your life, to craft a well-drafted memo and send it, who knows what could happen? But we have to do our parts.
Yeah.
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 So pivoting to strategic, intentional change when it comes to policy distribution of power, what does that change look like?
So from the public health standpoint, I know that WHO and the CDC and other federal health organizations are really focused on improving like the everyday conditions of life on a daily basis, the circumstances and how people are born and they live and they grow and they age and work and all of that stuff. So they're really trying to have a more holistic approach to how we are strategically having this conversation. And they're trying to tackle an equitable distribution of, we talked about power, we talked about money, we talked about resources, looking at all of those structural drivers and how those affect the conditions of daily life, not just on a national perspective, but also from a global and a local perspective also. So looking at the different levels, so community, individual, and systemic levels of things. So what we need to really focus on is how are we going to measure some of these problems? Because when it comes to social determinants, it's very difficult to measure some of these root cause issues where it's like, oh, well, this person is struggling from obesity because her father was incarcerated. How do you measure that? So those are some of the issues that we're trying to figure out. So that way, because we know that this happens, but it's the how that we're trying to figure out and operationalize, right? So that way we can evaluate the action, and we can create policies from it. So that's why I told you that third segment of ARC's research, that policy development side, that's why I love that so much, because it focuses on the how, because we've known the why and the what's for decades now. It's just, okay, how do we translate this to action? And so that way the policy reflects the data at this point. And so I would personally say two of the most critical investments that we can make would be, especially going into this next presidential administration, to help really address health disparities would be to improve the access to high quality education and to concentrate more on developing interventions in the areas of early childhood education, housing, urban planning, employment, and income enhancements. So, because a lot of people are employed, but they just don't make enough money, which is a huge reason why the ACA expanded the federal poverty level requirement. So it went from 100% of the federal poverty level to 138% because of the fact that all these people have jobs. So again, it's not that they're lazy. They just don't have the income to substantiate everything that they need to have their needs met. So that's why I say income enhancements. How can people make more money and be positioned to have build more generational wealth in their families?
Amen. All right. Well, Dr. Jasel Martin, we definitely appreciate you and the wisdom that I learned so much. I mean, the wisdom that was coming out and just pouring into us about the socioeconomic disadvantages in the healthcare system. If you are not enlightened, then you just need to listen to this again because she did an excellent job, and we definitely appreciate you for coming and being a part of our podcast. And to those that are listening, we appreciate you and thank you so much. And until next time, let's talk health. We'll be right back.